racing horse, and this is near and dear to Dr. Tobin and myself and Hans. Hans is the farrier that's on the committee. We've really been looking at new technologies to see how we can do with this. We're going to start with Dr. Rhodes Bell. He's a veterinarian in town, and Rhodes really does a great job. He's a surgeon. He understands this, and he kind of applied this to younger animals, which I found very interesting. Instead of going just for the adult older animal, he put it a little earlier. Am I incorrect on that? In the yearling. And it really is an interesting way of looking at it with Dr. Clara Fenger. And so they're going to tag team this presentation. And Dr. Keegan is going to come behind them from the University of Missouri to bring the science around and talk about it all. Okay. Dr. Bell went to Vanderbilt University. He then went on to Auburn University, and he did his surgical residency in Ocala. So I'd like to introduce Dr. Reynolds Bell and Dr. Clara Fenger. And by the way, we all love Clara Fenger because she's been around here with us forever at the Gluck Center, and she's one of the graduates of the Gluck Center program as well. So thank you. Come on, Dr. Reynolds.
A couple different things. I did grow up around here. I grew up in the thoroughbred industry. One way or another, ended up becoming a veterinarian. I jokingly said that, you know, I'd consider myself a fan of thoroughbred racing and the industry as a whole. I just happened to be a veterinarian. One of the cool things is, you know, I see what's going on and how we're portrayed in the press, and always wonder what could I personally do to help with that. And then luckily, Dr. Fenger came along and approached me with an idea she had, and it really fit well with what I felt like I could perhaps lend some light on the situation and what we might be able to do to fix that going forward. And I've been grateful for that opportunity, and wanted to share a couple of our early conclusions. The more we learn, how much more we have to go. But wanted to talk about lameness and racehorses in general. And one thing I want to point out is it's not exclusive to the racehorses, and I use a lot of this information in all of the horses that I see, the English performance horses, the Western performance horses. It's not an exclusive problem to the thoroughbred racing industry or standardbred for that matter. And I think that's worth emphasizing, you know, and just a couple of the common causes with, you know, in case you need some direction on where to look. You know, you've got your developmental orthopedic diseases, most famously osteochondritis dissecans lesions, juvenile arthritis as portrayed in that Hawk X-ray, and then I think everybody's seen those fetlocks on racehorses that, you know, as a consequence of athletic trauma. That these are all common causes of lameness. But one that we're kind of focusing more on in racehorses specifically are the stress fractures, and we really want to focus on this one just because we worry about, you know, this. Sorry, there's the circle for you in case you don't know where to look. That would be what some people would call a precondylar fracture and a fetlock on a racehorse. We're worried about these progressing on to a catastrophic injury or one that, you know, would have a significant impact on the horse's life and soundness going forward. So many of the catastrophic injuries that we're seeing in racehorses occur at these sites of stress fractures. And this pre-existing injury may manifest, and again, that's one of the things we're looking at, as a subtle lameness or asymmetry or a change in gait signature, which we'll get into a little bit more as we go on, what we mean by gait signature. It's just really, we want to see if there's an alteration in their usual way of going, as people say. So if we can detect that, potentially we can intervene before it progresses to that catastrophic injury. And that was obviously a pretty appealing premise for me to get involved with. So lameness or gait asymmetry, whether you're talking about a subjective evaluation or objective evaluation with these motion sensor technology, is determined by the difference in head for the forelimb or pelvis hind limb height over a full stride cycle. And luckily for you guys, if some of this doesn't land immediately, Dr. Keegan's going to fall behind and do a much better job of explaining this in the presentation to follow. But I think it's useful to hear a couple different ways in case that jives with your mind a little bit better. So this is a video, and first we've got the horse going at full speed, and then we'll slow it down a little bit. And so this, I always use the forelimb as the example. So we're measuring that maximum height for the right front. And I've been told I can't wonder, but I usually do my motion when I'm explaining this to clients. So for every stride, the horse is going to go down on the right front, and we get that minimum height, which is the next one, the minimum height, and then they push off, and you get that maximum height. And so we record that number, record that minimum, and then we do the same thing on the left front, the minimum height, and then the maximum height. And then for every stride, you subtract the difference from left to right for the minimum and the maximum. And for a perfectly sound or symmetrical horse, that difference we're doing. I always try to explain this isn't voodoo or magic. It's really just putting a number on what we're doing as veterinarians in our subjective evaluation and recording that on our computer in perpetuity. So this, I mean, I could talk for a couple hours on the limitations of a subjective evaluation, but this is just a couple of the little bullet points. But the detection for threshold for asymmetry as a function of our human perceptive ability is about 25% of difference from left to right. And they looked at, got a big group of experienced clinicians together and just tried to get them to agree on which limb was lame for subtle forelimb lamenesses and then subtle hind limb lamenesses. And that group of veterinarians could only agree about 3/4 of the time for the forelimb and about 2/3 of the time for the hind limb. So again, just briefly highlighting some limitations of the purely subjective evaluation. So subtle lameness in racehorses, the objective measurement of lameness or gait asymmetry overcomes these limitations of human perception. And here's a video that highlights one of those where, okay, you're supposed to say, is this horse lame in the hind end? Keep a close eye on that pelvis because that's how you're going to be able to detect it the best. And then we've got this horse trotting away who thinks he's part Arab and throws his tail up. And he's got a nice little fan obscuring the entire pelvis. Obviously, that's just a good example of, I wouldn't be able to tell you what's going on with the pelvis there, but we've got a sensor on his hind end there that is obviously able to see through that, if you will. So our little study, which is kind of a sister project to the one that Dr. Keegan's going to talk about, was just looking at, as Dr. Holland alluded to, young horses, sometimes even before they were broke or shortly thereafter, and then on into their training careers and racing careers. And we looked at them monthly versus in the other study where they're looking at them weekly. So just trying to figure out if we could identify injuries earlier than we otherwise could. And the goal is, we're a couple years in now, but we'd like to follow these guys through their racing careers and then even afterwards, if possible, as they transition to other careers until they're lost to follow up either through a claim or a sale to a distant land. So in this presentation, we're just talking about our preliminary findings, which sounds weird to say after we've been doing it for a couple years, but like I said in the beginning, still got a lot of work to do. And hopefully we're going to emphasize the utility of this objective lameness measurement in our racetrack practice. So we're going to show a couple case studies here and a couple points that I want to point out is the reference ranges that are established for the software. So again, we're talking about lameness locator. If everybody's heard of that, they're undergoing a identity crisis at the moment and rebranding to the Equinosis Q. So Equinosis Q and lameness locator are terms that are interchangeable. So those reference ranges were established for evaluating horses that are presented for lameness exams, meaning there's a perceived problem, and the client or the trainer brings the horse to you, evaluating it under that lens. And this is a different population of horses. We're just checking in on horses that are happy and healthy generally, doing their jobs well. So we're going to use a little bit of a different reference range, which I'll get into in a couple slides. And those reference ranges were established as the measured differences between maximum and minimum height of the head and pelvis over a stride when its lameness grade was 0, determined by 3 experienced clinicians. So that's where those thresholds came from originally. So in 19 and 20, a preliminary study was conducted, as I've been alluding to, in which racehorses were evaluated weekly over the course of a race meet for about 4 months. And a preliminary threshold based on that study for serviceably sound horses was chosen as 1 standard deviation of observed gait asymmetry among that population of racing horses. So this is just an example of the data output for, this is a forelimb analysis where every one of those sticks is a stride, and every one of those sticks, or sorry, the longer the stick is, the more asymmetric they are from left to right. And then that red one is an average of all those. So the forelimb is a little bit different than the hind limb, in which the minimum and maximum head heights of a stride cycle are biomechanically related. You can't have one without influencing the other, the minimum and the maximum heights. As I said, the rays in the forelimb plot depict the amplitude of head movement asymmetry for each individual stride. So, and again, that red ray is the average of all strides. And just the way the programming was set up, you're subtracting one number from another. If you end up with a positive integer that correlates with right forelimb asymmetry, and so that's going to be above the horizontal, the x-axis here. So everything above that is going to correlate with the right forelimb asymmetry, either lack of impact or lack of push-off. And then conversely, strides with left forelimb asymmetry are below what would be negative integers, so below that horizontal. And again, that threshold of detectable asymmetry amongst experienced clinicians is about 8.5 millimeters for the vector sum, which is, it's actually Pythagorean's theorem, a squared plus b squared equals c squared. The vector sum is the hypotenuse of that right angle triangle. And so that gray line actually correlates to 6 millimeters of difference from left to right for the minimum and the maximum, but we use that 8.5 millimeter for the vector sum. If anybody wants to get their calculator out and do the math on that, again, it's Pythagorean's theorem. So all the horses in this case series were evaluated using the serviceably sound thresholds presumptively established previously based on that study it was in Ohio and Iowa. So 1 standard deviation above that is 18 millimeters for head height. So we've expanded our circle somewhat for this, for our purposes. Same deal for the pelvis, but the push off and impact components of those are independent of one another. So we cannot combine them when evaluating them. All of the red lines correspond to lack of push off in that limb, and the green lines are lack of impact in that limb. And those original reference ranges are 3 millimeters of difference from left to right. And so our threshold for presumptively serviceably sound threshold is 7 millimeters from left to right. And so this is just going to be helpful when we're looking at these case studies on down the line. And we put their head or pelvis asymmetry in millimeters on this y-axis, and then on the x-axis is going to be our time in months. And we put those thresholds in as shaded areas. So if you see it above the shaded area, that's going to be outside of that threshold. And so for forelimb, again, we're at, oh crap, now I can't remember the number, 16 or 17. Oh. So, and then for hind limb, it's going to be a little bit tighter at 7 millimeters of difference. And again, that's the shading. And then I'm going to let Dr. Fenger talk about some of the cases that we've used this on where we thought it was helpful in their management. as long as she can talk, as soon as you need to tap out, let me know.
All right, don't go too far.
All right.
All right, thanks for having me here, and thanks Rhodes for being so gracious with your time and agreeing to do this study in the first place. Our first case is a horse that we started evaluating at 2. The horse was laid up for presumptive tibial stress fractures, kind of an inexpensive horse, so we didn't send him for a bone scan. But when the horse came up acutely lame after a workout, it was presumed to be a tibial stress fracture. Typically, we block the foot, and other than that, we don't do additional blocks on horses that come up lame out of a workout. And the reason for that is if you block a horse with a stress fracture, like the fracture that we showed you in a previous slide, you're putting that horse at risk of not feeling the fracture, and then you jog it, or let's say the horse gets loose and runs around the backside. You now have a horse running around with a blocked, potentially very serious injury. So as a general rule, we don't block horses that come up acutely lame out of a workout. Because of his age, and because it didn't block the foot, we presume that the horse had tibial stress fractures. And so we treated him as such. We laid him up, and I don't even know how do I advance this? I was gonna say.
So the keyboard right here, are you doing it over there, Rhodes, or where were you doing it? Oh, okay.
Oh,
There you go.
thank you. I know how to use it now. Thanks. I'm sorry about that. Technologically crippled. So for this horse was not part of our longitudinal study where we started them at yearlings. But I was just interested. And so I asked Rhodes to throw the lameness locator on this horse when we thought he was sound enough to start back in training. So this is what makes this case interesting. So you see that this horse was lame using our presumptive thresholds at this point, but because he was clinically way better than he started out, and I don't have examples of how he looked when he was really lame. And part of the reason for that is, of course, we don't jog horses that we think have stress fractures. We try to avoid that. So this was after 4 months of layup of stall rest and then turnout. And we were just playing with this lameness locator, so I didn't rely on the data from the lameness locator at all in putting this horse back in training. And he didn't get progressively more lame, but I didn't know how to change that line so that it's not directly to so the horse was, I'm going to say, right about the same amount of lame, and then all of a sudden, after a work, he comes up lame. And so that's the red arrow that you see. So we assumed we presumed it was a recurrence of the tibial stress fracture, which just literally means we put him back in training too quick. So we laid him up again, and this time you can see that we do have the progressive improvement of lameness. And then when the horse drops into this serviceably sound range, we put him back in training. And you can see that he did pretty well in training. And then he kind of followed the same pattern where after, even though he had been quite sound, after work, he comes up lame. This time, simply because the time frame of the stress fractures, at this point, you have either a chronic stress fracture. We were able to, at this point, radiograph him. I couldn't find the radiographs to show you, but we had radiographs of the tibia and showed that the tibias were not in danger. So at this point, when you're looking at this long of a period of time with tibial stress fractures, you would see a lot of active remodeling, and we didn't have that. So at this point, we felt comfortable going ahead with blocks. So we blocked this horse, And kind of surprising to me was that it blocked, in this case, it blocked directly to the foot. And when we block the foot, the lane was switched to the other side. So at this point, obviously now we're looking at the foot. And I'm going to ask Colby Tipton, who is the farrier on this horse, after hearing our story with this horse and looking at the horse, he's going to give you some input on how he managed the case. I can hit this whenever you want.
Yeah, I can operate that.
Oh, you just tell me when you're ready.
Yeah, when Clara and I come up with things like this and problems, and we, try to develop a solution, a negative palmar angle is probably, that's what we initially went after, and so immediately no toe grab behind, try to get the angle where it needs to be for whatever the problem was in there, which you found.
So what we did find was some sclerosis of the distal border of the navicular bone and suspected an esthesiopathy of the impart ligament, which is the attachment to the navicular bone. The radiographs of the other side were worse than this one. This is fairly subtle. We didn't do an MRI again because the horse is somewhat inexpensive, but that was a suspicion because of the sclerosis of the distal border. Go ahead.
So in that, like, to try to keep the angles and take the pressure off the navicular area totally, as much as we can from the ground up, then, you would not want a toe grab to raise the front of the foot and then put pressure in the back. I was telling Clara, I might mention too, that I do that with yearlings that are in prep and going to be sold. I really start to focus, especially, front always, but hind limbs more so when I'm trimming, to keep the toe back for ease of breakover, less stress on the limb from the ground up, because when you inhibit that by a toe grab or a long toe just on the hoof, everything else, the stress is magnitude like a lot. From the tendons to the bone alignment to the hocks to the pelvis to the back, all that stuff comes into play from impact ground up. And so we just did an XT, which is, it's not a toe grab, it's more of a wear played at the toe. And then as we started chewing him, trying to get the toe set back and, be focused on not letting it go any more than 4 weeks, or even looking at it, making sure that, in the winter months, they grow a little slower. So, we monitor, is the toe getting out there, and everything kind of remodeled and went good now. Huh?
So the primary treatment in this horse was corrective shoeing. Additional therapies that would be indicated in this case. This is actually the classic exact case for which a bisphosphonate would be recommended, but bis meaning children or osphos, but those are therapies that are currently banned, essentially banned in horse racing, so that they were not used. Shockwave similarly restricted, but shockwave would be another indicated therapy if it wasn't restricted due to medication regulations. And then corticosteroid injection of either the Cauthen joint and or the navicular bursa, that would be something that would be done immediately after it's diagnosed, and then probably not repeated, because at that point the corrective trimming and corrective shoeing should then carry the horse going forward. The end result is the horse raced successfully. This is between, and again, these are monthly evaluations, not weekly evaluations. So you can see at 17, I believe we did inject the Cauthen joint at that point, but the horse raced successfully between months 17 and 18 and finished third. And as you can see on the evaluation at 18, at month 18, you can see that that was after the race. So in other words, there was no negative impact of racing with this particular condition with the corrective shoeing. So that was a successful outcome. Thank you, Colby.
Thank you.
And so I'm going to mention briefly a second case. This is a horse that was a three-year-old and was entered in a race, first race in November 18th of 2020. He flipped in the gate and was vanned back, non-weight bearing, left hind. And an ultrasound could show traumatic fracture of the greater trochanter. So I'm going to show you kind of where that is and explain. There's just the hip of a horse. And there you can see the femur. There's the hip joint. And that is the greater trochanter. It kind of sticks out. So you can imagine if a horse flips hard enough in the gait, he's going to traumatically fracture that. And that's exactly what he did. And so this is what you're looking at on the ultrasound. You can see that's the top of the greater trochanter. 3 months. So the first evaluation was, same thing, non-weight bearing, really, really lame horse. We don't stick the lameness locator on those. Those horses are on stall rest. So we're not jogging them, not for the lameness locator or much anything else. Plus, we didn't necessarily know if there were other injuries in this horse that we couldn't see. But the first evaluation, you can see at month 1, the horse is still on rest. And then the second evaluation, which is 3 months after, we put the lameness locator on, and you can see that this horse is pretty sound. Interestingly, if you look at that diff min pelvis, which is the impact lameness, that all of those numbers are above 0, which means that's right hind, not left hind. The horse's injury was in the left hind. So the left hind had resolved, and this is the recheck ultrasound, and you can see a huge difference. I don't know if you can appreciate how. So ultrasound basically travels through tissue until it hits either air or something hard like bone. And once it hits that structure, it's reflected back to the ultrasound and recorded in an image. So you can see in the before picture how you got, just kind of picture it as just a bunch of little pieces like glass that are the fracture, the traumatic fracture of that greater trochanter. And then you can see that after, this is the 3 months later, once the horse is sound on the lameness locator, that you get a very smooth remodeling of the greater trochanter. And while the horse continues to have this sort of consistent right hind asymmetry, the left hind is essentially completely resolved. And the horse competes successfully in 5 races in this season and winning 2, and then basically sent home for a break after 5 races and just now starting back in training. Just note that that right hind impact asymmetry is consistent over time. Remember, the injury is on the left. So this is suggesting that this horse does have an underlying gait signature. And when I say gait signature, I mean an asymmetry, or you could call it, potentially you'd call it a lameness, but it's not necessarily associated with pathology. In this case, the horse's pathology was on the left. And most of those dots are within this serviceably sound threshold that we have. It's a preliminary threshold. As we continue our studies, we hope to get a better idea of where this threshold needs to be. I don't have time really to go through this in great detail, but I just want to point out this is one of the horses that we did start evaluating from a yearling. So you'll notice on exam 1, this filly is lame. This is before she's even broke. So, and there, no shoes, and turned out in the field. So point being, I don't know why she's lame, but she's clearly lame on this first evaluation. And then you can just notice that she has sort of a consistent right front and right hind impact. And just really quickly, this is her. She did ultimately, she fractured her sesamoid in a work. Interestingly, look at where she did that. So the two evaluations immediately prior to fracturing her sesamoid, she was as sound in front as she could be. So a couple explanations for that is, one is that was she actually fractured it 3 weeks after that week 9 evaluation. And so either if there was any pre-existing injury that we would have seen with this technology or just with a lameness exam, maybe it occurred or in that 3 weeks that we don't have an evaluation. Another argument is potentially this particular injury in this horse was not based on a pre-existing pathology. Because even though she has sort of the chronic right front, I don't think anybody's going to argue that the chronic right front mild gait signature was from birth. I mean, it's not something that was related to training. And then just to point out that we did the same thing. We waited until she was sound on the lameness locator before returning this horse to training. She had surgery. I did inject the ankle at one point, although she was still, and you can see that at months 14 and 15, while she's inside the serviceably sound threshold, she is higher than she started out with that right front slight asymmetry. I did inject her with Noltrex, and then she started working, and you can see that on her, but in between 15 and 16, she's had several fast workouts, and she at 16 is this basically very similar, if not spot on, where she started with her original gait signature. So there's no negative impact of increasing speed. This technology is super useful from the standpoint of my eyes cannot necessarily tell the difference between her exam at 15 and 16. But with this equipment, I can demonstrate that 16 is better than 15. So the take-home messages on what we found so far is that this technology has been a very effective tool, at least in this group of horses, to determine where horses can return to training safely. The next thing is a single lameness exam is not effective. And this data does give us a suggestion that a gait signature may actually be super useful for us. Both the gelding with the right hind gait signature and this filly with the left front gait signature, it suggests that that's going to be a useful technology to use. And of course, we need more data and more cases, and that is ongoing.